So, a very good morning to all of you. I, Dr. Poonam Joshi, welcome you all once again in our Saturday ACTRAC Head and Neck classes. Today's class is being taken by Dr. Kajari Bhattacharya. Dr. Kajari is Assistant Professor in Department of Radiology, Tata Memorial Center, and she will be talking on radiological anatomy of larynx and hypopharynx. So, welcome, Dr. Kajari. Please go ahead with the presentation.
Thank you, ma'am. Good morning, everyone. And I'll start the screen share. I hope I'm audible.
Yes, you are audible, Dr. Kajari.
Okay, thank you. Right. So let's start. So the topic of discussion today, as we can see here, is radiological anatomy of larynx and hypopharynx. And what I'll be doing is mainly I'll be discussing the normal anatomy of larynx and hypopharynx, and I'll be helping the participants to identify the landmarks, and finally how to identify the laryngeal cancers and their extension and locoregional extent as well as nodal involvement. So this is what I intend to do. I'll be doing mainly the pre-treatment imaging because post-treatment imaging is a separate class altogether. So let's start. So more than 95% of the malignancies in the laryngeal and hypopharyngeal carcinomas are SCCs, and they are closely associated with use of tobacco and alcohol, as we all know. Men are affected 5 to 10 times more frequently than women, and the incidence increases with advanced age, and a median age of diagnosis is around 65 years. The risk factors for development of the carcinomas of these regions include tobacco exposure, smoke exposure, occupational exposure to chemical irritants, and chronic irritation caused by reflux and virus. So let's start with the radiology part. So we know that clinical examination basically gives us the extent which is visualized clinically when we see the patient clinically. So the mucosal extent is very nicely delineated on clinical examination. However, submucosal and locoregional disease extension is delineated properly on imaging only. So we get to know the exact T stage and end stage of the disease. So the imaging modality of choice which we use for laryngeal and hypopharyngeal carcinomas includes a multi-detector CECT or a contrast enhanced CT because it is easily available and it is less prone to artifacts as it is faster. And since most of these patients have some degree of breathing difficulty, even if it's not a T1 disease, say it's a T3 or a T4 disease, which are most of the diseases which present to our institution or in any place in our country. So we use CECT because it is less prone to breathing and motion related artifacts. It is more comfortable for the patient also. So most commonly we use a 0.625 to 1 millimeter thick sections, which are basically very, very thin sections. And they're acquired in axial plane in a small FOV. And then we reconstruct them in the coronal and sagittal plane to look at the extent of the disease in total and for the measurement of the disease also. Now, contrast enhanced MRI is also used, but it is mainly used as a problem-solving tool. And we do a multiplanar T1, T2, T1 post-contrast FS and stir imaging for the evaluation of larynx and hypopharynx in such cases. And 4 millimeter slice thickness is the thickness that is usually used with 1 millimeter slice gap. But the problem with this is that it is prone to much more artifacts because the patients have become uncomfortable during imaging, and it is a long time taking imaging, which takes around 30 to 45 minutes. So it is mainly used as a problem-solving tool. So for example, if you want to rule out any prevertebral fascia invasion, or we want to rule out any subtle cartilage involvement, then we can do and contrast enhanced MRI. So for all practical purposes, CECT is the ideal modality of choice for imaging of larynx and hypopharynx. So let's come to identification of important anatomical landmarks. And basically what we are doing is we are going to see what are the boundaries of the larynx and hypopharynx, and we are going to see the framework, cartilages and bones of larynx and hypopharynx, the important membranes, and the vessels and prevertebral fascia, and how to identify them. So this, as we all know, that the nasopharynx is bounded inferiorly by the border of the soft palate, and oropharynx between the soft palate and the tip of the epiglottis. And below that lies basically posteriorly the hypopharynx and anteriorly is the larynx. So a larynx has multiple framework of cartilages, which we are going to describe later on. Hypopharynx continues up to the lower border of the cricoid cartilage posterior to the larynx. Now the subdivisions of larynx, so first we come to larynx. So larynx is subdivided into three parts, that is the supraglottis, the glottis, and the subglottis. Supraglottis basically starts from the laryngeal inlet, that is the tip of the epiglottis, up to the apex of the ventricle. So if this is the laryngeal ventricle, Then this is the tip of the laryngeal ventricle, and up to this is the supraglottis. Glottis is from the apex of the ventricle to 1 centimeter below it, and subglottis is basically the lower border of the glottis to the lower border of the cricoid cartilage. So this is what we all anatomically know. Now let us see what are the parts of it and how to identify them on CT. Now the supraglottis, the important contents include the epiglottis, the false vocal cords, and the area epiglottic folds. Other than that, there are arytenoid cartilages and two very important fat-containing spaces, that is the pre-epiglottic space and paraglottic space, and we'll see how to identify them and their involvement. Next is glottis. So glottis, most important contents are obviously the true vocal cords, and then the anterior commissure and posterior commissure. So let's see the framework of the cartilages and the bones which are present in the larynx. So the most superiorly located structure is this is the hyoid bone. And hyoid bone lies anterior to the epiglottis, and it basically divides the epiglottis into a suprahyoid and an infrahyoid structure, and that forms a subsite of supraglottic larynx, and that we'll see later on. Other than that is the thyroid cartilage. So this large cartilage is the thyroid cartilage, and below it is the complete is the C-shaped cartilage or the cricoid cartilage. Between the hyoid and the thyroid lies the thyrohyoid membrane, which is a weak area, which is represented by this circle, which is actually the point where the neurovascular bundle enters it. And this is the thyrohyoid membrane. And below between the thyroid and the cricoid lies the cricothyroid membrane. So if you look at the sagittal cut section of it, these are the various important structures. So the hyoid bone, the epiglottis. So that fat-containing space which lies anterior to the epiglottis is the pre-epiglottic fat space, and something which lies on the lateral surface of the larynx is basically the paraglottic space, which we'll see again later. This is the thyrohyoid membrane and the part where the neurovascular bundle enters it. The important folds of mucosa which connect the tip of the epiglottis to the base of the tongue and can help in transmission of diseases. This is basically the glossoepiglottic fold. And this is the point where the vallicula lies. So it's the hyoepiglottic ligament is present over which the glossoepiglottic fold lies. Next is the arytenoid cartilage. So arytenoid cartilage is a pyramid-shaped cartilage which has a tip through which the false vocal cord starts and it attaches with the thyroid. And the two processes which lie anteriorly in the pyramid, one is the muscular process and one is the vocal process. The vocal process gives rise to the vocal cord, and the muscular process gives rise to the thyroarytenoid muscle, which helps in the movement of the vocal cord. So this is the basic framework. This membrane is the thyrohyoid membrane, and this is the cricothyroid membrane. Now let's start to look at the CT anatomy. So if we look at the axial section, so whenever we start with the CT in the axial sections and we interpret it in the axial sections. Just to look for the disease extent, we can sometimes try a coronal or a sagittal section. So this is the hyoid cartilage as we see here. And what we're seeing is basically this is the epiglottis, and these two air-containing areas are basically the valliculae. Now, something which starts from the epiglottis and goes up to the arytenoid below is the aryepiglottic fold. So these are basically the aryepiglottic folds. And this part is your piriform sinus. So this is the piriform sinus. So the aryepiglottic folds form the medial wall of the piriform sinus. And beyond this lies the posterior pharyngeal wall. On the more inferior section, so this fat-containing space is basically the pre-epiglottic space, and it is connected by the hyoepiglottic ligament, and the mucosa is basically the base of the tongue. Now, next is the more inferior section. So this cartilage, which we see here, is a partially ossified cartilage. It's a thyroid cartilage. This is the epiglottis again, and these are the aryepiglottic folds. So this one forms the medial wall of the piriform sinus. This is the lateral wall, and this is the posterior wall. So this is the point where the neurovascular bundle is closely associated with the thyroid membrane. So this is the hyoid and this is the thyroid. So this is the region of the thyroid membrane. Now let's look at the fat-containing spaces. So this is basically the pre-epiglottic space as we saw in the axial section. So if we look at it in the sagittal section, this is a hypodense structure. So whenever we look at fat in CT, it appears as a hypodensity. And when we look at fat in MR, if it is a non-fat fat image, we see it as a hyperintense structure, whether it be a T1 or a T2 image. More importantly, if it is a fat image, we will see this again as a hypointense structure. So So we have to see this hyperintensity clearly anterior to the epiglottis. So this is the pre-epiglottic fat space, and this is the region of the glossoepiglottic space. Next, coming to the next important fat-containing space, that is the paraglottic space. The paraglottic space lies adjacent to the lateral surfaces of the supraglottis and the glottic larynx. What we see is this structure, which is seen as this well-defined hypodensity lateral to this air-containing space. And this is the area of the false chord, and this is the area of the true chord. So it ends at the level of the true chord. So it ends at the level of the glottic larynx, and it is very nicely identified till the level of the glottic larynx. Now, these spaces are extremely important because the involvement of these spaces upstages the disease to a T3 disease. So let's come to the next lower section. So we have seen the two uppermost sections. Next is the level of the thyroid cartilage proper, where we are seeing this is the tip of the arytenoid cartilage. So from the tip of the arytenoid cartilage will be the false vocal cord, which will be arising. So these are the false vocal cords. Lateral to the false vocal cords are these fat-containing spaces, which are basically the paraglottic space. Now, again, these are the aryepiglottic folds, and this is the piriform sinus of the right side, piriform sinus of the left side, and this is the posterior pharyngeal wall. Now, let's come to identification of the ossification of the cartilages. So what we see here is basically some part of the cartilage is ossified and some part of it is not ossified. So when it is a non-ossified cartilage, it looks like just like the soft tissue of the rest of the head. So when you see the muscle, it is almost like the muscle, the non-ossified part of the cartilage. And the ossified part of the cartilage looks like a bone. So it has basically a medullary cavity which has fat, which appears hypotense, as we can see here, and the cortex which appears sclerosed or hypertense. So it is extremely important to realize that thyroid undergoes a very inhomogeneous ossification, and some part of it remains unossified and some part of it becomes ossified, and it's an irregular process. But we have to compare the two sides when we are looking for whether there is any thyroid cartilage erosion or involvement or not. First, we have to see whether the disease is located adjacent to it. And secondly, we have to compare it with the opposite side, because as a whole, it simultaneously happens on both sides. So if we compare one side with the other, we can actually say whether this part is involved by soft tissue or if there is non-ossification of the thyroid cartilage in this region. At a more inferior level, where we can see the arytenoid cartilage is proper. So these are the vocal processes of the arytenoid cartilage, which gives rise to the true chord. Medial to the true chord lies the muscular process. The lateral to the true chord lies the muscular process from which arises the thyroarytenoid muscle, which is represented by this TA. And then is the paraglottic space, which is a very small fat-containing space at this level, and it ends at the level of true chord. Now, it is extremely important because once this paraglottic space is infiltrated, this means that the thyroarytenoid muscle is also infiltrated, and mostly in a glottic carcinoma, if the paraglottic space is involved, the larynx becomes fixed. Again, in this case, we are able to see how the thyroid cartilage is ossifying, and this part is the non-ossified part of the cartilage. Again, this is the top of the cricoid cartilage we are identifying. So this is the apex of the piriform sinus at this level. The more anterior mucosal membrane, which we'll be seeing here at this level, is your post-cricoid area, and the more posterior one is your posterior wall of the hypopharynx. So this is how we are identifying these areas, and as we will be seeing the anatomy and the involvement in pathology in future slides. So again, coming at the more lower level, so this is the level of the cricoid cartilage. Some part of the thyroid cartilage is seen. The piriform sinus ends here, and this is the post-cricoid area and the posterior wall of the hypopharynx. And there is basically the cricothyroid ligament or the cricothyroid membrane here through which the disease can go, and there can be an extralaryngeal extension. And finally, the same structures where we can see these are the lobes of the thyroid gland. Thyroid gland appears hyperdense in plain CT also because of the iodine concentration, and it enhances also. So these are the thyroid lobes of the thyroid gland. And this is the cricoid cartilage, which is partially ossified, the post-cricoid area, posterior pharyngeal wall. So again, short about the imaging appearance of cartilages in CT and MRI. So depends on whether they're ossified or not. So the epiglottis and the vocal process of the arytenoids are fibrocartilages that do not ossify. So these have a soft tissue attenuation on CT, and they have an intermediate signal intensity on T1 and T2. I'll show that. And the thyroid, cricoid, and arytenoid cartilages, these are hyaline cartilages, so they show progressive ossification. On CT, the ossified cartilages have hyperattenuating inner and outer margins with low attenuation of the medullary cavity. And on MRI, the ossified cortical margins are of low signal and the fat-filled medullary cavity is high signal. So anything which is fat has hyper signal in T1 and T2, and the cortex, that is the bone itself, appears black in MRI. So this is how cartilage looks like. So this is one of our patients. We can see this is an oral cavity carcinoma, but we are able to identify the anatomy of the thyroid cartilages very nicely. What we are seeing is basically this part is the non-ossified part, which has a same density as the muscle. So this is the bone window in which we are looking. And these are the ossified part of the cartilages. The fatty part appears hypodense. The fatty part appears hypodense in the center, and the cortex appears hyperdense. The similar thing when we are looking at MRI. So this is the thyroid cartilage. So these are the non-ossified parts of the thyroid cartilage, which have similar intensity as the muscle. And these are the ossified part of the thyroid cartilage. The central part, the medulla, that contains fat, is hyperintense. And this part is also hyperintense. And the boundary of it is quite black, basically, which is the cortex. Another important role of MRI is identification of the prevertebral fascia. So I will show it you in this slide only. So this is basically the cricoid cartilage, which has again partially ossified. So central part is hyperintense and the cortex is hypointense. Posterior to it will be the postcricoid area and the posterior pharyngeal wall. This line of fat, which we are seeing here, this is basically one prevertebral muscle and this is another prevertebral muscle. So this line of fat delineates the prevertebral fascia and the prevertebral muscles from the hypopharynx, and therefore the intactness of this and the breach of this is basically shows whether the prevertebral fascia is invaded or not. So sometimes what happens is, this is the line, if I show this red line, this is the plane which identifies it. Sometimes the tumors, they just abut the prevertebral fascia. In that case, the fat plane will be lost, but still the invasion of the prevertebral fat muscles will not be seen. So prevertebral fascia is a very tough fascia. In most of the conditions, we don't see, even if we see in CT, we can do an MR to confirm that it is just abutting the prevertebral fascia where the fat plane is definitely lost, and that is why it appeared that as if it is invaded in the CT, but MRI clarifies it and there is no invasion of the prevertebral muscle. Same, this is a T1 weighted image. We can see the subcutaneous fat is also hyper and this is also hyper. This is a T2 weighted image. Here also the subcutaneous fat is hyper and the non-ossified part of the cartilage appears like soft tissue and the ossified part of the cartilage appears like a bone. This is a post-contrast fat image, so we have to be very careful in this case. Here we can see here, this is basically the paraglottic fat. This appears black because it's a fat image. Here, the fat in this part of the bone, which is the ossified part of the cartilage, again appears black, and the soft tissue appears like soft tissue. So we have to be very careful. So it's a fat image. It appears like the medullary fat appears like the fat which behaves on the subcutaneous. Now coming to the parts of larynx and hypopharynx. So larynx is divided into supraglottis, glottis, and subglottis. Hypopharynx has three parts, that is the pyriform sinus, postcricoid area, and posterior pharyngeal wall. So let's come to larynx first. So the supraglottic larynx itself has multiple compartments. So at least three compartments are identified. So first is the epiglottis, and second is the aryepiglottic fold. Third are the false chords. Sometimes the epiglottis is also divided into a suprahyoid and infrahyoid epiglottis, as I told. So whenever there is a fixation of the vocal cord, the tumor becomes T3. And if there is any involvement of any of the fat-containing areas, there is a pre-epiglottic space, paraglottic space, it's a T3 disease. In laryngeal CA, that is basically it's a supraglottic, glottic, or subglottic, invasion of the inner cortex of the thyroid cartilage makes it a T3 disease only. And when there is through and through breach, it becomes a T4 disease. So whenever there is extralaryngeal extension, it's a T4 disease, and T4B disease means it's a very extensive disease when there is involvement of the prevertebral fascia, encasement of the carotid artery or mediastinal structure. So this we all know. We are going to see the example. So let's just look at the first subtype, that is the epiglottis. So when we are seeing the epiglottis, as I told, it is divided into supraglottic, in suprahyoid and infrahyoid. So this is a case of suprahyoid epiglottic CA, and this is the case of infrahyoid epiglottic CA. So infrahyoid disease, as we can see very nicely, has a more propensity to involvement of the pre-epiglottic fat more easily, because the pre-epiglottic fat is very close to this region. And therefore, we divide when we report it, we report whether the free edge of the epiglottis is involved or base of the epiglottis is involved. So this is an example of involvement of the preepiglottic fat. As you can see here, the soft tissue in the preepiglottic fat. This is again a case of epiglottic CA, where this is basically the epiglottis, and there is compression of the vallicula on the right side, involvement of the preepiglottic fat, and extension into the glossoepiglottic fold. Next is your arytenoid. So basically here in the arrows, what we are seeing is what are the directions in which this tumor can spread from the epiglottis. So first is the glossoepiglottic fold, when it goes more superiorly, involves the base of the tongue. In the preepiglottic space, more inferiorly, it invades the thyroid cartilage, and more laterally, it can go along the epiglottic fold along this medulla. So if the epiglottic fold is the epicenter of the disease can go more anteriorly into the paraglottic space, more laterally to invade the thyroid cartilage, and more posteriorly to extend towards the pyriform sinus. So basically, it forms the medial wall of the pyriform sinus. This is the case of an epiglottic fold. The bulk of the disease lies in this region. The pyriform sinus itself is free, but the disease is obviously bulging into it, and there is an extralaryngeal extension of this disease. There is involvement of the fat space also. The third subsite of the supraglottic larynx is the false vocal cord. So the tip of the arytenoid cartilage gives rise to the false vocal cord. If a carcinoma arises in this region, it can go more anteriorly. It can go more laterally towards the thyroid cartilage, and it can involve the paraglottic fat space, and then can extend more inferiorly, superiorly, or posteriorly. So this is the case of a false cord CA, where we can see there is involvement of the paraglottic fat, and the false cord is involved. So we'll see better, we'll look at better examples of these cases. This is just for the diagrammatic representation. Next, coming to the glottic SCC. Now, glottic SCC, as we all know, these are the most common of the subsites. So 30% of the cases are supraglottic, around 60-65% are glottic, and 5% are subglottic. So subglottic SCC are the most uncommon. If a glottic SCC arises, now it can go anteriorly to involve the anterior commissure, posterior to involve the posterior commissure along the paraglottic fat, and it can go along this thyroarytenoid gap and more posteriorly, and it can wrap around this cartilage, or it can directly go through and through the cartilage. In this case also, we have to remember that a T3 disease means there is fixation of the vocal cord, or there is involvement of the paraglottic fat or inner border of the thyroid cartilage, and same as T4 ST1. So this is a case of glottic CA. We can see this is the level of the thyroid cartilage. This is the arytenoid. So from here, the true cord arises. The true cord is involved. The paraglottic space is involved. It goes more inferiorly below the level of the cricoid cartilage to involve the subglottis, and then it goes through the cricothyroid membrane more anteriorly to have an exolaryngeal extension. Lastly is the subglottic SCC, which is the least common of these three, and here also we can see this lesion which is arising at the level of the cricoid cartilage, involving mainly the subglottis. The subglottic CA has a different type of drainage, and it can be sometimes more dangerous because it is very close to the thoracic structures, and involvement of trachea and esophagus can be seen sometimes in these cases. So let's see the pattern of spread of laryngeal CA into the deep spaces. So we'll be discussing the patterns of spread in the deep spaces and the patterns of exolaryngeal spread. So if we look at the deep spaces, so what is the implication if it goes to the preepiglottic space? It has a higher frequency of nodal metastasis. It has a poorer response to RP, and high tumor volume lesions that extensively involve the anterior epiglottic space often involve the thyroid cartilage also because of the direct extension. Now, superior extension into the BOT also happens in these cases along the glossoepiglottic fold and the lateral pharyngeal wall along the pharyngoepiglottic fold. Next is the paraglottic space. Paraglottic space again expresses the tumors to T3 due to the involvement of the thyroarytenoid muscle. These tumors are often associated with focal cord paresis. Now, tumor infiltration in the paraglottic space carries a lower response to RP, along for local control. So it can go into the preepiglottic space, it can go into the paraglottic space. Third is the transglottic spread. So transglottic spread means it is going from one subsite to another, from the supraglottis to the glottis, or from glottis to the supraglottis, and plus minus subglottis. The subglottis may or may not be involved, but transglottic spread means spread from one subsite of the larynx to the other. And that can happen through the mucosa, it can happen through the fat also, or it can go through the exolaryngeal extension. Next is the subglottic extension or the cricoid involvement. Now, subglottic extension is often much better observed on imaging than by laryngoscopy. So it is very nicely seen on the imaging. And soft tissue within the airway is observed at the level of, whenever it is seen at the level of cricoid cartilage, subglottic extension should be of concern and should be carefully evaluated. And if there is an increased risk of cricoid cartilage invasion, obviously because it is at the level of the cricoid cartilage. So we'll next is the patterns of extralaryngeal spread. Now the extralaryngeal spread happens in either of the three ways. So first is through the thyroid membrane. So this is the weak part of the thyroid membrane where the neurovascular bundle is in close relation. And from here, the disease generally goes across the thyroid membrane and shows an extralaryngeal extension. Or the second part, that is your cricothyroid membrane, where it can go anteriorly, as I showed in one of the previous cases. Or it is directly through the cartilage, that is, it destroys the thyroid cartilage and goes up, so shows a through and through extension. So let us see some examples of these. So this is the extension along the thyroid membrane. So this is a case of a supraglottic CA, and there is involvement of the epiglottic fluid and epiglottis and pre-epiglottic cascade. So what we are seeing here is basically this disease is extending in this is the region of the neurovascular bundle, as we can see, and this is the this is the area from which it is exiting. So one thing which I forgot to show in the normal slides, which I just intend to show to you in these slides, is basically identification of the vascular structure. So this is your artery. One of these will be the artery and one of these will be the vein. I'll show you how to identify. So this one, which is a little collapsible and is not exactly round, is basically the internal jugular vein. The one which is rounded is basically your common carotid artery or internal carotid artery, and that is much more important to identify, because if there is an encasement of the internal carotid artery or common carotid artery for more than 270 degrees, then it becomes an inoperable disease. So that we will see in future examples when we see the notes, that's how it looks like. Okay, so again, this was the across the thyroid membrane. Across the cricothyroid membrane, if we see, so this is a disease which is involving the glottis extending to the anterior commissure, and it is extending below at the level of the cricoid, and it is just extending here more anteriorly. The fat here is not seen, so basically there is extension along the cricothyroid membrane. So here again we are identifying these two vessels. So these are basically the internal jugular veins, and this is the common carotid vessels. So this we have to see very clearly. One atherosclerotic plaque is also seen in this case. So if there is any significant disease burden in the form of atherosclerosis in the neck vessels, that also ought to be reported, which can have consequences in the post-procedure due to infarct and stroke. Okay. So this was, so I'm deviating from my point. The first was the disease extension across the thyroid membrane, disease across the cricothyroid membrane, and finally through cartilage erosion, where we can see through and through erosion of the thyroid cartilage. So it is completely destroyed. As we can see here, we have to compare it with the normal size. There is soft tissue in this region, whereas in this part, this is already occupied. And there is disease outside the larynx also. So this is the destruction of the cartilage, thyroid cartilage, and direct disease extension to the exolaryngeal compartment. Let's come to the hypopharynx and its subtypes. So hypopharynx is a portion of the pharynx that extends from the plane of superior border of the hard bone or radicula to the plane of the corresponding to the lower border of cricoid cartilage. This we all know. Now the best thing is another important thing is that fluoroscopy or a barium swallow, it nicely demonstrates the mucosal anatomy of hypopharynx. So as we can see here, these are the valvulae, and then the hypopharynx starts. So these are the pyriform sinuses. This is the apex of the pyriform sinus. And sometimes mucosal lesions are much better identified on barium swallow. So if you're looking at a very small lesion, which may not be identified on CT, but it is only a mucosal proliferative lesion, then it is much better identified on a barium swallow rather than a CT. So barium swallow has an important role when we are looking at hypopharynx lesion. So the subtypes which we ought to look at include the pyriform sinus, that is, and the lateral posterior pharyngeal walls and the postcricoid region. So let's start with the pyriform sinus. So the pyriform sinus extends from the pharyngoepiglottic fold of the upper end of the esophagus to the upper end of the esophagus at the lower border of the cricoid cartilage, and it is bounded laterally by the lateral pharyngeal wall and medially by the lateral surface of the aryepiglottic fold, arytenoid, and cricoid. So this we all know, it is bounded medially by the aryepiglottic fold and more inferiorly by the arytenoid, and laterally it is bound by the lateral pharyngeal wall. So this is the coronal reconstruction, shows beautifully the anatomy of the pyriform sinus. So these are the pyriform sinuses, and this is the apex of the pyriform sinus. normal piriform sinus should look like this on a coronal image. On an axial image, we can see these are the piriform sinuses, the small lesion which is arising from the medial wall of the piriform sinus, and it is projecting into the piriform sinus. So these are the very small lesions which can often be very well appreciated, if not on CT, then on barium swallow. Next is the post-cricoid area. The post-cricoid area extends from the level of the arytenoid cartilages connecting the folds of the inferior border of the to the inferior border of the cricoid cartilage. So this is how a post-cricoid area should look at. So this is a very nice CT which demonstrates this cricoid, and these are basically the thyroid cartilage lower parts. And what we are seeing here is this layer. This is basically your post-cricoid area. This is a thin layer which separates it from this. This is basically your posterior pharyngeal wall. So this dotted area is your post-cricoid, and the more posterior one is basically your posterior pharyngeal wall. Again, a fat layer separates it from the prevertebral. So this actually very nicely demonstrates the collapse post-cricoid area and the posterior pharyngeal wall. So this is the post-cricoid carcinoma, where we can see here, this is a tumor, which so here we can nicely appreciate the posterior pharyngeal wall, which is separate from this post-cricoid area. So this is the post-cricoid carcinoma, which is possibly extending into the glottis also, sorry, supraglottis also. So what we are basically seeing here is this post-cricoid carcinoma. Nicely, the tumor, this bulge is very nicely identified. The post-cricoid carcinoma is a little bit different from rest because it is more commonly seen in females who have a long history of dysphagia and iron deficiency anemia. So it sometimes occurs as a result of Plummer-Vinson syndrome, which is a triad of esophageal webs, iron deficiency anemia, and dysphagia, and later on it gives rise to a post-cricoid carcinoma. So this has a little bit different epidemiological profile as compared to the rest of the carcinoma. Next is the final is the posterior pharyngeal wall. This is the carcinoma of the posterior pharyngeal wall, which is arising here, bang on. And what we're identifying is still here the prevertebral fascia fat is maintained, so therefore it is not invading into the prevertebral muscle. This is the carcinoma which is arising from the posterior pharyngeal. So if you look at the staging of the hypopharynx, it is different from the staging of the laryngeal carcinoma, as in the size is important in this case. And other than that, if there is any involvement of the thyroid cartilage, it directly becomes a T4 rather than T3 disease if there is only inner cortex in erosion, as in case of an esophageal carcinoma. And one more important thing is that the esophageal mucosa involvement and esophageal muscle involvement is different. So it's a T3 disease if it's a mucosal involvement, and it's a T4 disease if it's a muscular involvement. Now, this is not always identified very nicely in CT. So for involvement of the esophageal mucosa, there is a direct inspection, which is much, much better. And for in esophageal muscle involvement, is very nicely seen on CT. This is the case of hypopharyngeal carcinoma with a large nodal mass. So as we can see here, this is the carotid on the left side, and this is the internal jugular vein. The carotid on the right side is seen, but it is quite significantly averted by the lesion. So basically around by the node, which is around 180 degrees. And the IJV itself is not seen. So we have to look at the extension, how much, if there is a thrombus in the IJV, we have to look at the skull base, at how much superior the disease is extending. In any case, hypopharyngeal carcinomas are primarily do not undergo surgery at first if this is a large bulky disease. So, but still we need to look at the nodal mass of the primary disease. Next, come to the patterns of spread. So again, on the deep spread and deep spaces and the extralaryngeal extension. So if the deep spaces we are considering, it goes to the paraglottic space through the thyroarytenoid gap. So basically, if this is a lesion in the piriform sinus through the thyroarytenoid gap, it can go more anteriorly to involve the paraglottic space. So here we can see a lesion in the hypopharynx which goes more anteriorly and involves the paraglottic fat. Prevertebral muscle infiltration, as I already told, so this is a large lesion where we can see that the prevertebral fat is absent, the fat vein is not seen, but in the MRI, this is the role of MRI which we can see very nicely. This prevertebral black line, there is a prevertebral fascia, is still intact, so it is closely averting, which may not always be very nicely seen on CT, but MRI delineates the anatomy very nicely. So prevertebral, in case of prevertebral muscle infiltration, this muscle will go and it will be occupied by the tumor. And sometimes the vertebral artery, which is these two black dots, these can also be encased. Next is the involvement of the post-cricoid and esophagus. So if there is more inferior extension, then the esophagus also appears bulky. This is the level of the trachea. We can identify the thyroid glands here. And it goes more inferiorly to involve the esophageal mucosa. If the esophageal mucosa is involved, it becomes, if the esophageal muscle is involved, it becomes more bulky. And whenever we see a disease, it becomes more bulky. If there is only mucosal involvement, it may not be identified on CT. Next is the extralaryngeal extension that can happen across the thyroid membrane, as I already told in this case, through the membrane. It can happen along the wraparound around the pharyngeal constrictor muscle. So what happens is, like it is extending in the thyroarytenoid gap, it may go along the pharyngeal constrictor muscle, wrap around the posterior aspect of the thyroid cartilage and show an extralaryngeal extension. Along the cricothyroid membrane and the joint. So from here also the disease extension can happen, and again through direct cartilage invasion, as I showed in a previous case. So this is a case where there is direct erosion of the posterior part of the thyroid cartilage and extralaryngeal extension. Lastly, coming to the nodal involvement. So the levels which are most commonly affected in CA hypopharynx are level 2, 3, and 4, and 6, depending upon the level and which of the involvement. So if the disease is at a higher plane in the piriform sinuses, then 2, 3 are more involved. If the disease is lower in the posterior pharyngeal wall or the post-cricoid area, then these levels are more likely to be involved. However, any of the levels can be involved in the CA hypopharynx. In the CA supraglottic CA, level 2, 3, 4 are more commonly affected. CA glottis, if it is only a limited disease, a T1 disease or a T2 disease, it generally does not show any lymph node metastasis. However, when there is a transglottic extension, definitely shows according to the area which is involved and the area which the lymph nodes drain in that area. And if it's a CA subglottis, then the central compartment nodes and the paratracheal nodes and the delphian nodes are more commonly involved, and we need to look at these then. So how to identify necrosis and a nodal involvement? So whenever we see a node which is rounded, which shows loss of fatty hilum, as in this case, so this is a CT and this is the MRI, we can see the node is enlarged. So there is a size criteria. So that is, if it is more than 10 mm, then it is considered significant. And if there is enhancement, if there is loss of the fatty hilum or the loss of the elongated architecture. And secondly, so this is basically, as we can see here on the opposite side, this is a small node which is maintained fatty hilum, it's small in size, whereas on the right side, you can see this involved node at the level 2. Not only that, further involvement will be seen in the form of necrosis. When you can see here, this is the hypodensity with central necrosis in the CT, and it appears hyperintense in T2 weighted image, and again suppression in a T1 weighted image. So basically, it's a fluid signal. So it appears hyper in T2 and hypo in T1, and it appears hypodense on CT. So when the nodal necrosis is present, it has a higher chance of showing extranodal extension. So we have to see at extranodal extension and loss of fat planes, loss of this well-defined capsule which was seen in this case, that is lost here. Whenever we see that, we have to look at the relationship of these vessels, of the node with these vessels. We have to see the relationship of the node with the vessels, as we can see here. So here, nicely, the common carotid vessel, the internal carotid and the external carotid are very nicely seen here. So in this case, the fat plane is maintained between them, and there is no encasement. So in this case, there is no obvious vascular involvement by the node. So this and all we have to report in our imaging findings. So that more or less ends my presentation of a pre-treatment imaging of laryngeal carcinomas and radiological anatomy. Now we'll see a few of our own cases, and we'll see how to report them. So what we are seeing here basically is a case of a patient who presents with a hoarseness of voice. So there's a small lesion which is present in the anterior part of the vocal cord on the right side. There is no involvement of the anterior commissure. It's basically a pedunculated lesion. If we see here on the coronal imaging also, it just shows a mild irregularity. The paraglottic fat is maintained bilaterally very nicely. So this is a small T1 lesion of the larynx. On the contrary, we see of the glottis, basically CA glottis. Another case of CA glottis, where we have seen that there is extensive involvement of the both cords extending along the anterior commissures. The anterior commissure is involved. There is almost closure of the airway, and If we see more anteriorly, it is causing the erosion of the inner cortex of the thyroid cartilage along the extension of the anterior commissure. So there is erosion of the inner cortex only. And more superiorly, if we see, the paraglottic fat here is also effaced at the level of false cord. So this is a T3 disease. Another one is the third case, where we can see here is this right vocal cord lesion. Now, this right vocal cord lesion extends up to the anterior commissure, and more inferiorly, if we see, there is extension along the cricothyroid membrane. So this is the cricoid cartilage. This is the thyroid cartilage. So in between, the disease is extending more anteriorly into the exolaryngeal compartment, goes on the right side and wraps around the right side of the thyroid cartilage. So in this case, we have to be very sure. So whenever we look at sclerosis, so this is a very important point which we need to emphasize on. Now, thyroid cartilage has a very low specificity for sclerosis in the form of, if there is a sclerosis, and the specificity of involvement of the thyroid cartilage is very low, which is around 40 to 50%. So if we see sclerosis of the thyroid cartilage, it may be due to just the inflammatory component of the disease that the cartilage appears sclerosed. So until and unless we see erosion of the thyroid cartilage, whether it is a inner cortex, outer cortex, or through and through, we should not say that the thyroid cartilage per se is involved. But on the other hand, if you're looking at the arytenoid cartilage, this also appears sclerosed. So this cartilage is actually involved, though I don't think this carries much of an implication for the treatment. But still, this arytenoid cartilage is definitely involved, but the thyroid cartilage, we should not see that this is involved until and unless we see an erosion. But there is a disease extension along the cricothyroid membrane. This is a contradistinction to the adenoid cystic carcinoma. So sometimes other carcinomas which have a submucosal spread, they don't show any mucosal abnormality and may not be well identified on clinical examination. So in this case, we see there is the disease is not at all identified in the airway. If we see here also, the airway looks very nice, but there is submucosal extension and involvement of the thyroid gland, exolaryngeal extension, as we can see in the axial as well as coronal images. So in these cases, again, imaging becomes extremely important for locoregional disease extension. Another case, this is a case of a supraglottic CA larynx. What we are seeing is a right aryepiglottic fold lesion. The piriform sinus is still seen, but it is just involving the lateral wall of the piriform sinus. The space is still there in the piriform sinuses. What we're seeing here is, this is the area of the neurovascular bundles with minimal exolaryngeal extension of this disease. And again, if we go more inferiorly, the paraglottic space is involved at the level of the true cord. So basically, it's a transglottic CA with an epicenter in the right epiglottic fold with an exolaryngeal extension. In this case, also, we have to see that there is a small node here which is identified on the right side. And in spite of it being small, it should be an indeterminate or a suspicious node because first of all, it is a supraglottic CA, and there is involvement of the fat as well as the paraglottic fat, as well as there is exolaryngeal extension. So this is a suspicious node, and we should, if it is not very clear on CT, then we can undergo, should do a USG or a guidance FNSE if we need to rule out any nodal involvement in such case. But obviously, this is a small node, and there is no involvement of the vascular structure. Another case. So what we are seeing here is again a supraglottic CA. Now supraglottic CA extending along bilateral epiglottic folds, so it is seen going more posteriorly. So this is the epiglottis, the posterior margin, sorry. The posterior margin of the epiglottis is also involved. These three epiglottic fat spaces pair. So this is a more posterior growth. Here again, no cartilage involvement. There is no cartilage erosion, so the thyroid cartilage looks fine, and there is no no glottic extension also. But if you look at this one, this is a more of an anterior supraglottic disease, where we can see there is involvement of the epiglottis, and it is going along the glottoepiglottic fold to involve the vallicula and the base of the tongue. So the base of the tongue involvement is very nicely appreciated in this case. And again, it is going around the lateral pharyngeal wall also, along the pharyngoepiglottic fold, as we can see here in the left, on the left side. So it's a supraglottic lesion with extension to the base of the tongue and the lateral pharyngeal wall. Finally, the last case, again, an extensive supraglottic disease. So it is involving both aryepiglottic folds, the piriform sinus. Also, it is getting involved secondarily. There is involvement of the base of the tongue and the vallicula. It is growing more inferiorly to involve the post-cricoid area also. So it's a very extensive disease. Not only the disease is extensive, the nodal involvement is also quite extensive. So there are large necrotic nodes with a necrotic nodal mass at level 2, 3. which shows extranodal extension and partial encasement of the vessels on this side. So basically, we are not able to identify. So these are the vessels on the left side. The IJV is not at all identified on the right side. The common carotid is also closely abutted by the nodal mass, so there is no, this not more than 180-degree encasement. On the lower level also, we are identifying level 3, level 4 nodes and supraclavicular nodes also. So it's a very extensive nodal disease, and already by the time the patient presents to us, the patient has metastasis in the lung. So this is a very extensive disease, and patient has to go for palliative management. So after palliative CPRT, the present patient, we can see that the disease burden itself has significantly decreased. So this is another finding which I have not discussed in this case because I'm discussing mainly the pre-treatment imaging. So what we are seeing is this edema in the soft tissues, which is very commonly seen in post-treatment, post-RT cases of larynx, of any kind of radiation post-RT treatment changes. So this should not be confused with disease. These are basically the subcutaneous edema. The nodal mass has also decreased significantly in size, and the primary disease is also significantly decreased, which is only limited to the left piriform sinus now. But after some time, the patient presents with difficulty in breathing, and we can identify significant increase in the nodal mass. The primary remains almost the same, but the nodal mass is significantly increased. There are brain metastasis, there are pleural metastasis with collapse of the right lung and multiple left lung parenchymal metastasis also. So with this, I'll finish my presentation. A few take-home messages. So the first thing is that CCT of neck and thorax is the imaging modality of choice to determine the locoregional disease extension and screening of metastasis of laryngeal and hypopharyngeal cancers. MRI has to be used as a problem-solving tool only. 95% of squamous cell malignancies, but the rest of the 5% are malignancies which may not present with mucosal abnormalities, and therefore imaging again plays a very important role in those cases. And to identify the disease, first you have to identify the normal anatomy and landmarks, followed by the epicenter, the subsite of disease involvement. And if we follow the fat infiltration, deep muscle involvement, we can actually look at the extension of the disease very nicely, followed by the exolaryngeal disease extension, nodal involvement, and metastasis. So thank you for patiently.
Thank you, Dr. Kajari. Excellent presentation. And I think there are a couple of questions also. And I think we'll be uploading this soon in our this recording of this video. So it will be available.
Okay.
Yeah. So Dr. Kajari, can you please take 2 questions are there?
Yes.
Yeah. So in MRI, how does a thyroid cartilage look like in T1 and T2 and fat suppressed sequences? Which structure?
Again, I'll show. So I have already shown this, but I'll again show for clarification. Yeah. So let us look at the MRI. So this is a T1 weighted sequence. How to identify a T1 weighted sequence? The CSF. So this is your vertebral body. This is the spinal canal. So whenever the CSF around the spinal cord appears bright, it's a fluid signal. So basically, it's a T2 weighted image. When we are seeing it as black, then it is a T1 weighted image. So this is how you easily identify a T1 versus T2. The vessels appear black in any kind of MRI, which is a non-contrast MRI, which we're using because of flow void, which we call as. So vessels we see as black. These are the muscles and basically the soft tissue. So these muscles will appear a relatively little bit brighter on a T1 weighted image than the vessels. So these are the muscles. So basically, once we identify the muscles, so these are the prevertebral muscles, these are the sternocleidomastoids, and these are the strap muscles of the neck. So this cartilage is actually the thyroid cartilage, as we can see identified here on the CT. So if you're looking here on the MRI, this line is your, so this part, as you can see, this part is an ossified part and this part is a non-ossified part. So this part, which looks like soft tissue, is the non-ossified part of the cartilage, which will look like the muscle. Again, if you're looking at the ossified part of the cartilage, which looks like a bone. So bone has a thin black cortex outside and a medulla, which looks bright. So medulla contains fat, so this appears bright. The cortex appears black. So this is the ossified part of the cartilage, which looks like a bone. This is the ossified part of the cartilage, which also shows similar signals. So thin black cortex outside, the medulla appears bright because of fat. whenever you're looking at a T1 or a T2 weighted sequence, you should always try to look at the subcutaneous fat. So if it is a subcutaneous fat is bright, then it is a non-fat sac sequence. If it is subcutaneous fat is black, then it is a fat sac sequence. So whenever it's a non-fat sac sequence, this fat will appear bright, the cortex will appear black, and the soft tissue will appear as the soft tissue density of the muscle, which we are seeing. Similar in T2 also. So this is the medulla, which has fat and it is bright. The cortex is black. Similar here, and this is the non-ossified part of the cartilage, which looks like the muscle. This is also a non-fat sac sequence because we can see the subcutaneous fat as bright. Whereas this is a post-contrast fat sac sequence. So generally what we acquire is a post-contrast fat sac sequence only. A non-fat sac sequence is not acquired in a post-contrast sequence. Here we can see the vessels as bright. So this is the IJV, these are the common carotids. And this is basically, these are the muscles and this is the fat. So the fat appears black. Here again, we can see the paraglottic fat appears black. So this part, which was the ossified part of the cartilage, again looks like this, that is the fat. So this is also slightly of a intermediate intensity as we can see the subcutaneous fat. So this is the fat, and this part again, this black line which is surrounding it is the ossified part of the cartilage. So cartilage which is ossified, that looks like a bone, will always look black. So the cortex always looks black. The fat will look like the subcutaneous fat. This again, this part, actually it is difficult to differentiate on a post-contrast fat sac sequence whether there is a cartilage involvement or not, because the soft tissue and the fat starts looking similar. So when we are looking at cartilage involvement, we should always look at high resolution in sections, non-fat sac T1 and T2 sequences for identification of cartilage.
Thank you, Dr. Kajari. I think this would explain them. There's another question, if you could take that. The question is, what is the significance of sclerosis of laryngeal cartilage in the context of tumor involvement?
So the thing is that it has been shown that the specificity of involvement of laryngeal cartilages as to the in form of sclerosis is around 40 to 50% for thyroid, and around 70%, 60 to 70%, or sometimes even 80% also when we are looking at arytenoid and cricoid cartilages. So if we are looking at cricoid and arytenoid cartilages, and if there is evidence of sclerosis, we should say that these cartilages are involved. On the contrary, if we are looking at the thyroid cartilage and it shows sclerosis, we should be a little bit careful in calling it as involvement, because generally what happens is when there is a tumor inside or outside, this area, the cartilage itself becomes inflamed and it shows sclerosis. Sclerosis as a reaction of inflammation secondary to the tumor present to it is a more common phenomenon rather than the tumor actually being involved in the thyroid cartilage. So for thyroid cartilage per se, we have to be a little bit careful. So whenever we are seeing erosion or lysis, then only we should say that the cartilage is involved. If there is only sclerosis and we are not able to demonstrate any through and through extension through the cartilage itself, we should not ideally call it as a cartilage involvement for thyroid cartilage. But for arytenoid and cricoid cartilages, we should say that the cartilage is involved in the form of sclerosis, whether it is it's a erosion or lysis. So in the case of arytenoid cartilage, the terminologies will be sclerosis, erosion, or lysis if for involvement. For cricoid also the same, but for thyroid only erosion and lysis are important and not the sclerotic component.
Dr. Kajari, there are, I think, how and when to use MRI as a troubleshooter?
So yeah, MRI, as I told, basically are used for mainly two things. We should be very fast in imaging these patients because already they are in the gantry. It's first an uncomfortable situation. It's a longer examination procedure, and if there are breathing related artifacts, then it doesn't solve our purpose. So we should use it in a very targeted manner. First is when we are looking at the cartilage involvement. So sometimes if we want to know whether this there is intracartilage, so if CT is not giving you a clear picture, for example, most probably in the cases where there is an inhomogeneous ossification of the thyroid cartilage, then to look at the intracartilaginous fat, which we are seeing here in this case, this fat, this is very nicely seen in our MRI. So if we are able to show the disease, if we are seeing soft tissue intensity in that region, then we can say very clearly that cartilage involvement is present. First is this. Second is the prevertebral fascia involvement. So this, as I have already shown, this is the prevertebral layer of fat which separates the hypopharynx from the prevertebral muscles, and anterior to it lies we face, sometimes it is not very clear on CT whether actually there is prevertebral fascia abutment or if there is prevertebral fascia invasion, especially in hypoenhancing lesions. So if it's a very enhancing lesion, then it is like where quite clearly delineated, no, the prevertebral fascia is muscles are not involved. But if it's a poorly enhancing lesion, then the fat plane abutment does not show very clearly whether actually disease is involving the prevertebral muscles or not. In those cases, if this disease extends up till this plane, as I showed in one of the cases, then we can actually clearly demonstrate that the prevertebral fascia is just abundant, it is not involved. So therefore, it is important for the staging of the disease. Otherwise, it will become a T4B disease. So yeah, so in one of these cases, so in the CT, as we can see here, it is not very clear whether, so this is the prevertebral muscle. So if we look at very carefully at this region and this particular point, we are not very clear whether there is involvement of the prevertebral fascia or not. But if we do MRI in such a case, so this is the same case we see here, this prevertebral fascia is very nicely seen and the prevertebral muscles are quite clean. So in these two cases, MRI is very helpful to us. Sometimes, very rarely in vascular involvement, we can use it, but generally these are the two main indications where MRI is used.
I think, Dr. Kajari, there are two more questions. Role of pre-treatment tumor volume for supraglottic and glottic larynx carcinoma.
Yeah, so the tumor volume is basically calculated. Tumor volume is closely related to the final outcomes. I don't really remember the exact percentages, but how we calculate it, basically, we measure the tumor dimensions in three planes. So always we do it in 3 planes only, that is the AP, transverse, and superior inferior extent. And then we have a mathematical formula that is basically A into B into C into 0.523. So this is how we calculate the pre-treatment volume. So pre-treatment volumes, especially in laryngeal carcinomas, are extremely important, and therefore they should be given in most of the cases. I do not remember the exact prognosis in the terms of percentages that my clinical colleagues might be able to help you.
Right. I think there is a long question. Do we use ADC values in TWI for diffusion weighted images for hypopharyngeal lesions due to the effacement and the possible difficulty in imaging early hypopharyngeal lesions or disease recurrence process? Or does it help in NIRAD scoring as a troubleshooter?
Yeah, so basically diffusion imaging, most commonly what we use in diffusion imaging is in tongue cancer. So it has definitely a prognostic value in tongue cancers when we look at the nodal involvement. So when we're looking at very sub-centimeter nodes and we are not sure whether this, because sub-centimeter nodal involvement is very commonly seen in head and neck cancers. And in those cases, when we're looking at the nodes, then actually your diffusion weighted imaging is quite helpful. Also for identification of smaller lesions, obviously it depends upon the histology of the lesion also. If it is showing diffusion restriction, then it can be easily identified. But the problem with diffusion weighted imaging is that generally the resolution of diffusion weighted imaging is not that great. So for only very focal lesions, it is very easy to identify, but for diffuse mucosal involvement, I would not say that diffusion is a very helpful imaging. For NIRADs, I really don't know. I have to actually read about it, that how much is the role of diffusion in NIRADs. But I would presume that in any form, if there is a diffusion restriction, obviously it represents a tumor recurrence because there is a tight packing clump of cells which is causing the diffusion restriction. So definitely diffusion will give you an idea whether there is a new, especially in case of NIRADs, because what happens is the anatomy itself is so distorted, the fat planes are so distorted that it is sometimes becomes very difficult on CT to actually say whether it's a fibrosis or it is a disease recurrence. And obviously, if the disease is showing diffusion restriction, fibrosis never shows diffusion restriction, then it becomes easier to identify. But how much is the utility and how is that we need to see, and I also need to read about it.
So I think, Dr. Kajari, there are a lot of questions. We'll be taking these last couple of questions. Yes. I think how to find epicenter of tumor in large tumors for adequate staging.
Yeah. So that is very important. So what happens is that if it's a large tumor, so for example, it becomes very difficult in a supraglottic laryngeal cancer, which is involving the hypopharynx, and because these are very closely related. So for example, if the epicenter of the disease is in the aryepiglottic fold and it is involving the piriform sinus secondarily, then it really becomes very difficult. So what we have to see is where is the bulk of the tumor. So most of the times what happens is generally wherever is the bulk of the tumor is the most necrotic part of the tumor, because it starts in that region and starts necrosing in that region because of the growth of the tumor around it. So wherever is the larger, most bulky and necrotic part of the tumor, there we should consider as the epicenter of the disease. The rest of the disease which starts growing in the periphery is a more vascularized part of the tumor. So therefore, it's less bulky and it is more vascularized, so there is less necrosis. So wherever is the bulk of the tumor, that is majority in the chunk of the tumor, the thickest part of the tumor and the most necrotic part of the tumor is then the epicenter of the tumor. So we can identify mostly by that, but sometimes still this is not a foolproof thing, and we can actually sometimes not delineate the but such large lesions when we see which is involving from one compartment to the another, they generally have extralaryngeal spread, and we generally place them in a T4B or a T4A disease only. And sometimes just looking at the disease, we can stage it just like that. For smaller lesions, sometimes it may be difficult, and for that cases, we have to see how much, where is the bulk of and most necrotic part of the disease, which can give us the idea about the epicenter of the disease.
Thank you, Dr. Kajari. I think last question. Role of dual energy CT over MRI in assessing the early cartilage invasion.
Yes, dual energy CT also has a very important role, and it can actually show these cartilage over MRI. I'm not very sure, but definitely over CT, it delineates the smaller lesions very nicely and the cartilage erosions also, because it uses two. One is the lower energy and one is the higher energy, and these enhancing lesions, they give the image in the form of a color flow. It's a color image, colorful image. So that gives a very clear delineation of which part of the tumor is enhancing, and a very small tumor is also very nicely delineated on a dual energy CT. That much I can say. That is another role of dual energy CT which we see is basically for cartilage erosion also. I am not very sure how it goes over MRI particularly, but definitely over normal CT, dual energy CT definitely has a role.
So with this, I thank Dr. Kajari Bhattacharya for so patiently answering each and every question. And it was really an academic feast, Dr. Kajari. And for the first time, I think in these 2 years, we have running classes. Today, we reached our 100 full delegates or the attendees, and we could not allow more to attend.
Okay, so thank you, ma'am.
Congratulate you for the same. And I thank everyone. Thank you. Thank you, Doctor.
Thank you, ma'am. Thank you.
Thank you.